And then the people who walk in, they can just join us here at the very front row, who is always empty. Welcome, everyone, and welcome to all of you that are joining us via Zoom. First of all, can you all hear me at the back? Excellent, thank you. We're incredibly pleased to have all of you join us here tonight for our first and what we hope one of the many opportunities that we will create on interprofessional learning. I know that we often tend to learn, study, and tend to work in silos, and yet we know that optimal healthcare requires and happens in a collaborative learning environment. And that environment requires that we all understand, value, respect, and appreciate what other professions bring to the table. And one of the ways to get there and to create this healthcare team of the future, which is all of you here in this room, is interprofessional education. So that's one of the pedagogical approaches that we're trying to use as a lever for the healthcare team of the future. As mentioned, I'm incredibly pleased that this is one of the many opportunities, so I hope that you're aware that the third Monday of each month, starting today, fourth Monday of each month, starting today, we have identified, in collaboration with some of you in this room, some emerging topics, starting with substance use disorder, cultural humility, indigenous health, and so on and so forth, that I hope would be relevant and will speak to each and every one of you, being held in the same room at the same time. So hopefully you'll join us for the rest of them as well. Before we get started, I just want to mention some logistics. There is a paper going around in attendance. If you could fill that in, if you haven't done so already, please do. It will help us get a better understanding who is here in the room. And it will also help us reach out to all of you after the session and ask for your feedback and your thoughts in terms of what you'd like to see in future sessions. What are some of the topics that are of interest to you? And some reflections on how it impacted your learning. So please do sign up. There are some refreshments at the back. Please feel free to get up and help yourself. I realize it's almost 5 o'clock on a Monday afternoon, so do anything that you need to do to feel energetic and feel like you can participate and contribute. So help yourself to those treats at the back. Other than that, we're talking, as mentioned, we're talking about the healthcare team of the future, and I'm absolutely delighted that we actually have 3 different professions represented here tonight. So you'll see the interprofessional team modeled here on the topic of substance use disorder. I'm pleased that we have Dr. Adam Newman, who is a physician with the Department of Family Medicine. We have Shannon Fraser, who is a mental health social worker at the Kingston Health Sciences Center. And we have Meghanne Hicks, who is a nurse at the Kingston Health Sciences Center. All 3 of them will have some exciting cases. You can see the posted flip chart over there. So get ready to be engaged and inspired. The floor is all yours. Thank you so much. Just forgot to mention, we have people joining on Zoom. So what I'll do, you'll see me here monitoring the Zoom account. And anytime they have questions and you want to put them in groups, I heard you have some cases and some group work, then I will deliver and transmit some of the questions to you and to the rest of the team. So I can do that moderation there, if that helps. Wonderful. Thank you so much. Floor is all yours.
Thank you very much, Claudiana, and it's a pleasure to see so many people here tonight, and we will really, I heard that you can do whatever you need to do to energize yourselves. We will try to do whatever we can not to bore you. We would just be interested to know the breakdown or the spread of disciplines here in the room. Could I just ask for a show of hands? Could everybody who is training to be an occupational therapist raise their hands? Wow, all right. And what about physiotherapist? Hey, okay, you're rare. And nursing? And what about medical students? Great. All right, so that's a good mix. So yes, as Claudiana said, we are going to present a case, a fictionalized case of a real occurrence which happened at Kingston Health Sciences Center, and we would like to ask people at that point. We're going to try to mix things up and divide you into groups with at least a couple of disciplines in each group. And I forgot to ask how we just advanced this probably by pressing the little arrows, right? So first off, we do have to talk about any disclosures. This usually means relationships that pose a conflict of interest with industry. For our intents and purposes, none of us have any of those. So Shannon and Meghanne had nothing to declare. I did want to declare the fact that I'm an addict in recovery. I do that partly because it's one of the reasons I do the work that I do, but also partly to address stigma, which is a really big burden on people with addiction disorders. I don't need to tell you that addictions are often looked upon as failings, as moral failings, as bad behavior because people are stupid or criminal or irresponsible. And that often, in many cases, it's true that people with addictions do engage in behavior which is criminal, but it is recognized as a brain disease, and it's just important for all of us to realize whenever we're talking about any groups of patients that we don't want to other them. We don't want to talk about them as that group of people who have that difference. There are people in every walk of life and in every profession who have addiction disorders. So, having said that, what is START? You'll notice that our name actually doesn't have the word addiction in it. This was a name we arrived at. We started as a multidisciplinary team. The first meeting was actually myself and a medicine resident and Shannon from social work, who recognized that there was a problem that KGH, Kingston Health Sciences Center, didn't have a team which specifically addressed substance use disorders or addictions. And there's a shift. This tells you something about the status of this disease, that there's always a little bit of ambiguity about what term we use. So people will often fade in and out between talking about addictions and substance use disorders. For all intents and purposes, we're going to use the term addiction here. But we deliberately didn't put that in our title, the Substance Treatment and Rehabilitation Team, because a lot of people will resist being labeled as an addict. I mean, if they're told that they have the addiction medicine team coming to see them, their backs will get up, they will get defensive, they will be in denial because they feel that they're being judged as being people who have done something wrong or less than. And we deliberately wanted to avoid that so that we could be as low barrier as possible, so that people would be more accepting of our attempts to step in and be helpful to them. So the objectives, we're just going to go over the definition of addiction and talk a little bit about the epidemiology, the prevalence and the frequency of addiction among patients. We'll show you our case study, which I said is a thinly fictionalized case of a real patient. We hope that by the end of this, we'll all be able to understand the benefits that a real multidisciplinary cooperation could bring to a care of a complicated patient, such as this one, which is quite typical of patients with substance use disorders. They tend to be complicated, difficult to manage illnesses. And finally, we're going to have you discuss the potential contributions that each of you in your respective disciplines could bring to the care of patients like this that are seen by the START team. So, just to remind everybody, if you look at the Diagnostic and Statistical Manual from the American Psychiatric Association, the so-called Bible of psychiatric diagnoses, there is no diagnosis for addiction. It doesn't exist. We diagnose people as having a substance use disorder. And there's a long laundry list of 11 different criteria that people have to meet in order to be diagnosed with a substance use disorder. But, for all intents and purposes, again, we can equate substance use disorder with addiction, and you can boil it down to 4 C's. So think about people who exhibit the loss of control over their consumption of a substance or their engagement in a behavior. So this can apply to both chemical addictions like alcoholism, cigarettes, marijuana, crack, or behaviors like compulsive sexual behavior, compulsive eating, compulsive gambling. They're very much the same disease. So loss of control, compulsive use, as I said, continued use despite negative consequences. That's a really critical one. And finally, the persistence of cravings for the drug or for the behavior, even when somebody has had a long period of abstinence. So not due to withdrawal, not strictly due to withdrawal. People will feel an almost physical urge to continue to go back to their substance or go back to their behavior after they've reached remission. So just in terms of epidemiology, addiction and substance use disorders are very common. So whereas 1 in 5 Canadians are diagnosed with a mental illness at some point in their lifetime, 20% of people who are diagnosed with a mental illness actually suffer from an addiction as well, and vice versa. A large proportion of people with addictions, probably in the order of about 2/3, will also have a concurrent mental health disorder. And about 1 in 10 Canadians report symptoms consistent with illicit drug dependence. So a large proportion of male drinkers and a smaller proportion, but still quite significant, of women who drink alcohol actually would meet the criteria for high-risk drinking. We all hear about the opioid epidemic every day in the papers. 200,000 people are actually thought to be addicted in Canada to specifically prescription painkillers. So that does not include people who are addicted to heroin or to fentanyl that they purchase on the street, but these are prescribed medications. And billions of dollars are spent every year. At the same time, again, speaking about stigma, this is something that people generally keep a secret and hide from their healthcare providers. So they don't talk about it, and they won't tell their physician or their primary caregiver about their disorder. The hospitals have the sickest of the sick, and it just stands to reason that addiction is only more prevalent within hospitalized patients. So various surveys have been done to look at the prevalence of problematic substance use in hospitalized patients, and it's big. There's a lot of people who are in the hospital any given day of the week who are there because of their substance use. This is just some more recent and local stuff. So Ontario, this shows you the increasing rates of opioid deaths. So these are overdose deaths caused by opioids. And the point of these, the various colors just show each of them is a different opioid. The point here is just to de-emphasize the whole fanatical talk about fentanyl and carfentanil. It doesn't much matter. Opioids kill people, prescribed opioids as much as illicit opioids, and you can see that however much the different trends have changed in terms of what opioid people are using and dying from, people continue to die in large numbers. And this is a plot just showing the numbers of people admitted to hospital and who present to the emergency department with addictions, with opioid use disorders and related to opioid use addiction. And this is what prompted us to come together. So this is why 2 years ago, being the front line of seeing people come in day after day, week after week, with serious illnesses caused by addiction, not just opioid use disorder, I mean, that's the headline-grabbing one, but all the other addictions cause people to come into the hospital and spend prolonged periods of time in the hospital. We wanted to do a survey of hospital patients to show that it actually was a problem that warranted some effort on behalf of by the Kingston Health Sciences Center to address. So for 1 month alone, the month of June in 2018, we asked all inpatient teams, and we were kind of loose about it. We asked, it could be a physician, it could be a nurse, it could be a social worker. Are you aware of a patient in the hospital right now who's there because of addiction or whose treatment is being complicated by their addiction? Yes or no? And if they said yes, we actually collected their medical record numbers. We checked to make sure that we weren't getting multiple reports on the same people, because in fact sometimes we did. But we boiled down to 124 separate people in the month of June alone. And we picked June because that didn't include St. Patrick's Day or homecoming or the 1st of July or any other big holidays when people tend to overdo it, or New Year's Eve. It was just June. And 124 patients in the hospital at that time here in Kingston had an addiction which was significant. This is just a sort of handy way of looking at how frequent the different diagnoses were, and you can see that infective endocarditis really stands out there, and in fact, that is about the most serious thing that can happen. Short of death from overdose, about the most serious thing that can happen to a person because of addiction is that they inadvertently push bacteria into their veins when they inject themselves. The bacteria take root in the heart and start to grow and cause a fungating infection in the heart, which can kill them. And that's a big one. So speaking about being multidisciplinary, we had referrals from lots of different disciplines within medicine, just because people, when they're admitted to hospital, tend to be under a particular medical service. But what was interesting is that if you look at the substances that were identified as being responsible for the person's addiction and their illness, the big legal three at the end, and of course marijuana wasn't yet legal at that point. That was in June. Remember, marijuana wasn't officially legalized in Canada until October. But for all intents and purposes, if you take legal substances, they account for the majority of the problems that people are experiencing. Of course, opioids on its own is the single largest, but lumped together, it's legal substances that are causing problems. And finally, we asked people, if there was an addiction service here at Kingston General, what would you want help with? And most of the answers did not relate to, on the close end here are things like initiating medication or dealing with pain management or withdrawal. On the far end, on the right side, it's dealing with basic social needs, counseling, discharge planning, and outpatient connections. So it was really somebody to deal with the broader determinants of health, not just prescribing medicine, but what is it about this person's life that makes their life unmanageable, chaotic, and dangerous, and how can you get them set on the right path once they leave the hospital, once they're finished treatment. So, I'll let you look at this. This is a quick outline of this patient. This is a young guy. Well, I think he's young, 28, very young. Probably not to you guys. But he was admitted after being transferred from another hospital where he came in heart failure, which is very unusual in a 28-year-old man. And what was notable, and again, I realize that everybody has different backgrounds, and forgive me if this is overly medicalized, but I will ask if there's any questions. So basically, this guy had a congenital heart problem when he was a baby. He had to undergo several heart surgeries. He had an artificial valve implanted in his heart. And he had not been, the latest that was known about him prior to his admission is that he hadn't been showing up regularly to have his clotting, his therapeutic anticoagulation monitored. So people with mechanical heart valves are supposed to take blood thinners for the rest of their life to stop them from forming blood clots around the little metal gaskets that are implanted in their hearts. And this guy had not been showing up. He hadn't been returning calls. He didn't get his blood tested properly. When he did get it tested, he wasn't therapeutic. So there was something wrong with his follow-up. He wasn't getting properly followed. So maybe at this point, I'm just going to ask for people to shout out or put up your hand if you have anything else you'd like to know about him.
And if anyone has questions as we go along at all, just feel free to raise your hand and ask them. We want this to be as interactive as possible. So Boris, in addition to his medical problems, he also has quite a compromised social history. Let me flip forward here. There we go. So Boris grew up rurally with the domestic violence between his parents. There was alcohol addiction on both sides of his family. He dropped out of school in grade 10, but found a job as a laborer. However, that did not last. He currently is on ODSP, or as it's more commonly referred to, welfare or social assistance. In Ontario, for a single person, although Boris has children, a single person makes $1,300 a month on welfare if they secure housing, as well as just their basic needs. Boris does have 2 children, 2 and 4 years old, with different mothers. He was first prescribed opioids following a mechanical valve replacement in 2008. So it was a doctor that gave him his prescription for opioids. And at the same time, as when his health started to go downhill, his marriage was breaking down, and his dad, who had been a lifelong drinker, was diagnosed with cirrhosis. Has anyone heard of the ACEs study? Few hands? Okay. So for those of you who don't know, the ACEs study is called the Adverse Childhood Experience Study. And essentially what it says is that for every bad experience, if you will, as a child that you have, the odds of you having addiction, being an abuser, having chronic health problems increase. And it's from the CDC. It's a really, really good study, and there's been lots more information on it. So by looking at this, Boris has a fair number of strikes against him, if you will. He has violence in his family, there's addiction. So we know that the profile of someone that uses substance often goes along with having a poor social and historical health status. Okay, I'm going to pass it back to Dr. Newman for the more medical piece. Again, we did try and make this as relevant to all of you as possible, to not be too medical. So feel free to raise your hand if there's pieces you don't understand, because I sure did when we went through this.
So thanks, Shannon. So just to sum up here, what this is telling us is that so the subtherapeutic INR refers to the test of how well controlled his blood clotting is, and that's not good. 1.2 is not good. It means he's not taking his medication, probably. He also has bacteria in his blood, which is definitely not good. You're not supposed to have bacteria in your blood. And on echocardiogram, he's got his aortic valve, the valve that was replaced, is not functioning properly. Blood is sloshing back and forth through it when it shouldn't be. And there is a mention in the chart that he had a past history of injection drug use. That was all that was mentioned. So anything else anybody would like to know? So, good question. Boris was actually couch surfing before coming into hospital. Are you familiar with that term? Yeah. So he was staying at friends' places. He wasn't actually living at home, because he and the mother of his second child were going through a stressful time and were separated. Anything else? Yeah, in the back. That's a good question. And so the question was, what are the social supports? That's a very broad question. In fact, no, this is good. Again, I told you this is a real case. Honestly, I don't know, because this was not well handled. He was not, a full history wasn't taken from him. He did have a social worker who knew him, who came to visit him in the hospital from his home community, who as much as said that he didn't have very good social supports, that his family was not much help to him, and they were kind of in disarray. Yeah, go ahead. Okay, good question. So has he been using any other substances besides opioids? In fact, at this point, the question of his drug use was not addressed. So at this point, he wasn't asked, and if he had been asked, he would have denied that he was using opioids improperly. Yeah. So at this point, he had been at the other hospital for a day. He'd been there for 24 hours. I think he'd been there for long enough for his blood culture to grow bacteria. So it was at least 24 hours, but not much longer than that. Yeah. So good. A history of previous hospital admissions or emergency department visits. Lots and lots of hospital visits here in Kingston, because he was a long time. He was a pediatric cardiology patient for many years. He had multiple surgeries, but not hospital admissions. I presume you're thinking maybe about suspicious ones, where somebody shows up and says that they ran out of their painkillers and they need more. So no, there weren't a lot of admissions that seemed to be clearly related to substance use. Good. So is the prescription medication covered? So in fact, he was actually a step for, so Shannon mentioned OW, Ontario Works, which essentially is available to anybody who is unemployed and doesn't have an income. He actually had qualified for an Ontario Disability Support pension, which pays a little bit more money to people who have a medical reason for not being able to work, and it includes drug coverage. So he was getting drug coverage. And maybe I'll just cut to the next slide here, just in the interest of time. Oh, All right, let's hear. So one question was a urine toxicology screen done? And what were his values? What is important to him? So, no, nobody did a urine tox screen. And so a urine toxicology screen is to look and see what substances, so this relates to what somebody asked before. Is he actually using something currently? Does he have something in his system? Nobody did a urine toxicology screen. Nobody asked him about his drug use. And at this point, nobody, as far as I know, nobody talked to him about anything other than his symptoms and his physical symptoms. So all good questions to keep in mind. I just want to go now and show you his medication. What did I? Yeah, because what happened to the slide with his? Oh, there it is. Okay. So just because medications were mentioned, so these are the medications that he's on. So first of all, hydromorphone. I guess I won't keep asking, does everybody know what that is? Because you won't tell me if you don't. But hydromorphone is a powerful opioid. It's also, the brand name is Dilaudid. And it is probably the most, the epidemic started with oxycodone, right? OxyContin was the brand name. That has been clamped down on and taken out of commission. Now, mostly when people use an illicit prescription opioid, it's hydromorphone that they use. So that's maybe a red flag. He already has a prescription for hydromorphone, which he's supposed to take every day. He also has prescriptions for amitriptyline, which is an antidepressant, and clonazepam, which is a benzodiazepine or a tranquilizer. So that might suggest to you that he has had some psychiatric problems or some emotional problems that somebody felt it was worth prescribing something for. In addition, trazodone, the next one down, is also an antidepressant which is often used for its sedating properties to help people fall asleep. So there's at least 3 medications there, amitriptyline, clonazepam, and trazodone, which suggest that at some point a doctor thought he had some kind of emotional or psychological problem that warranted treatment. And then metoprolol is a beta blocker, and warfarin is the blood thinners, Coumadin. So just worth noting that anybody, like the medical student taking the history on him, would have written these all down, and this might have been an opportunity to think a little bit about what's going on with Boris. Does anybody have questions about what these medications are and what they mean? Yeah. In fact, so the question is, why is he on such a huge dose of warfarin? In fact, usually the way warfarin is prescribed is because what he wasn't doing was he was supposed to be having his blood tested once every week or once every 2 weeks, and then the coagulation nurse would call him and say, hey, your INR is only 1.2, you should increase your warfarin. So they generally they prescribe a large amount on the understanding. Some people do actually take huge amounts. It might, but really what this means is that he probably is not taking 24 milligrams. That's a good question, but he's probably not actually taking 24 milligrams because, as you saw, his INR was only 1.2. Right? So the more Coumadin you take, the higher your INR should be, which roughly is the longer it takes for your blood to clot. Anything else about drugs? I'm going to go back. So here he gets on April 11th. So keep track of the dates, and we will hand out to you a little outline of the case so that you can sort of keep in mind the sequence. So on April 11th, he arrives in Kingston after a day or two at the peripheral hospital. He's already on antibiotics, right? Because they've already identified that he's got bacteria growing in his blood. He's getting heparin, which is to take the place of Coumadin to try to thin his blood so that he doesn't get more clot forming around his heart. And he's not he doesn't have a fever, but he doesn't feel well. He's short of breath. He has chest tightness, and his legs are swollen. Anybody want to just suggest what the significance of swollen legs is? Heart failure. Yeah. So again, this is a sign that his heart is not dealing with the amount of blood that it's supposed to be pumping out through his lungs. So a little bit more history, going back through, and this is stuff that I just found out when I went back long after this admission and looked in his chart. I found that he had before, I think around 2008, presented to emergency. Sorry, that was wrong. There was a presentation to emergency at least once with intractable vomiting, which at that time was thought to be due to the amount of marijuana he was consuming. And somebody in 2010 in a cardiology clinic note says, significant quantities of alcohol, 20 beers a night, 1 pack of cigarettes, also marijuana once per week. How much marijuana does somebody smoke if they smoke a lot of marijuana? Anybody have an idea of the quantity? Not you personally. I mean, this is probably an example of somebody of somebody lowballing how much they use. Right? He's been asked by a cardiologist who's seeing him because he's a heart patient and he's had all these heart surgeries. He's probably not, it's probably quite significant that he was able to say, yeah, I smoke some marijuana sometimes. He probably wasn't going to tell them that he smokes a couple of grams every day. Right? If he was smoking enough marijuana to have cyclical vomiting syndrome, which is a not unusual side effect of consuming huge quantities of marijuana, he probably was consuming quite a lot of marijuana every day. But you can see that in 2010, somebody did note that they had told him that he should stop drinking and smoking marijuana. And just recall what we put up the 4 C's, that the definition of addiction is that people continue to use despite negative consequences, right? So a treatment for addiction, nowhere in the treatments for addiction does it say tell people to stop using their drug they're addicted to. That doesn't tend to work. But so far, this is the only thing in his notes that suggests that anybody ever addressed his addiction. So there's his drugs. So he's admitted to the Department of Medicine. On the 12th, the day following, infectious diseases consulted because of the specific bacterium that he's still growing in his blood, and they suggest changing his antibiotics. He has another echocardiogram, so an ultrasound of his heart, which shows that he's got severe aortic regurgitation, massively dilated aortic root filled with abscess. Doesn't sound good, and it's not. So basically, his artificial valve is infected. Fluoroscopy shows that the valve isn't working properly, and the CT of his chest, the computed tomography of his chest says that this looks like the valve is actually becoming loosened from where it's supposed to have been planted in his heart, and he also has an abscess in his spleen. Any questions about this? Okay. So, not surprisingly, cardiac surgery is consulted. This is on April 13th, so 2 days after he's admitted. And they said he should have the valve replaced, but they said this would be high risk, and the wording that the surgeon used was the source should be controlled, which I think was a cryptic way of saying this is going to be very risky surgery. The chances are good that he might die. And anyway, there's no point in doing it if he's going to continue to inject himself and infect his blood with bacteria from his skin. But that's about as close as they got to addressing it. But somebody picked up on that and again told him, hey, Boris, you need heart surgery. It's really risky. You might die. Whatever you do, don't inject drugs. And so he wasn't feeling very well. He sort of stayed in bed. He was bored and in pain. On April 16th, so 5 days after admission, he leaves the floor, and when he comes back, the nurse is suspicious, and here a urine toxicology is done. And lo and behold, not only does it have, so opiates and benzodiazepines, we know he was being prescribed clonazepam, we know he's being prescribed hydromorphone, so the fact that he's got opiates and benzodiazepines in his blood doesn't necessarily mean anything, but THC, the duration of THC, tetrahydrocannabinol, the active ingredient in marijuana, is variable, but methamphetamine only lasts in the urine for a couple of days. So this really suggests that he has been using methamphetamine recently. So on April 16th, finally, the addiction medicine team was consulted. And after a talk with him for the first time, he He did admit that he had been recently injecting drugs. So IDU stands for injection drug use. And he seemed quite overwhelmed and frightened and worried, and he agreed to have a visit from somebody from a 12-step fellowship. Does everybody know what 12-step fellowships are? Shout out the name of one. AA stands for? Yeah. Any others that people know about? What's NA stand for? Yeah. And this is anybody another one? Here's a hint. Think of any drug and then put an A after it. Like there are hundreds of anonymous fellowships, 12-step fellowships. Yes, in this case, in Kingston, there's only Narcotics Anonymous and Alcoholics Anonymous, but he volunteered that he would like to have a visit from somebody from Narcotics Anonymous. He agreed to take some information about opioid agonist therapy because he did admit that, sorry, go ahead. No. Had he been connected with NA in the past? No, he had never attended NA. So opioid agonist therapy is methadone or buprenorphine, Suboxone, which are used to replace an illegal source of an opioid. And he agreed to, so he admitted that he still had this vomiting going on, this nausea, and he claimed that was why he was still smoking marijuana. Remember, his urine was positive for THC, and he said, yeah, he does. When he goes out for a smoke, he smokes marijuana. And it was pointed out, well, that might actually be making your nausea worse. How about if you try Nabilone, which is a synthetic form of THC, which is prescribable, which doesn't cause euphoria, it doesn't make you high. It's a way of trying to sort of helping someone decrease the amount of marijuana they smoke. So he agreed to that. A couple of days later, somebody from NA came and met with him, and he had a very emotional meeting with this person who told him, look, I'm an addict too. The person who came to visit him actually had himself been in the hospital requiring heart surgery because of injection drug use. So he had a very similar history to Boris, and he was able to tell him, I know what you're going through because I was there, and listen, I've figured out a way not to use drugs anymore, and I go to these meetings and they help. And Boris found that very, very therapeutic and helpful, and he broke down crying, and he said, I've never been able to admit before that I am actually an addict. So, and the reason that he and his baby mama were not living together was because she had discovered that he had been injecting. She had caught him injecting, and he hadn't yet told anybody that. So that was why he was couch surfing now. So we started a microdosing regimen of buprenorphine, and that's very technical why you would have to do that, but essentially this was in order to transition him from, because all the medications that you saw the list of before, they were continued while he was in the hospital, so he's still getting hydromorphone, but he was probably getting other stuff and using it on top of that. That's why his urine tox only said opiates. It doesn't specify which opiate or opioid it is. But he agreed to this. The transition needs to happen gradually, and importantly, in the first few days that somebody begins taking buprenorphine, it doesn't actually do anything for your drug craving. You actually a person will continue to, the reason you use microdosing is because somebody is still using full activity mu opioid agonists like morphine, heroin, fentanyl. So the buprenorphine started, but it would not yet have had any therapeutic effect. And indeed, the next day, the nurse found injecting equipment in his bathroom. And the next day was Monday, and the cardiac surgery said, well, forget it. We're not operating on him. They said, maybe we can transfer him to Ottawa. Who knows? Maybe they'll do something. And he arrested 2 days later and died. And just interestingly, at no point in his admission were any other disciplines consulted. Not consult liaison psychiatry to talk about why he was on amitriptyline, not occupational therapy or physiotherapy to deal with the fact that he was not getting out of bed, and certainly not social work to talk about any of the issues about communicating with his family. So this was something that we identified as being rather remarkable, and that's why it seemed like a really good case to discuss right now.
All right, so that's Boris. So I'm just being mindful of time, but we definitely want to give you guys some time for discussion. So we'll move along here. Okay, so what could have been done differently? I think it's pretty apparent that there was some things lacking with Boris's care. A full addictions care team would have been able to introduce and implement a treatment plan to help Boris succeed in substance use and other goals. Does that make sense, everybody? Everyone agree? Anybody disagree? Okay. What else, just based on what you saw there, could have been done differently for Boris? Was there anything? Yeah. Mm-hmm. No, absolutely. That is possibly the most social work answer you could have given. So to those that are joining us, the answer was to provide a more holistic approach to care, looking at not only the medical and cardiac issues, but why he was using, what was the root of his substance use. Mm-hmm. Absolutely, yeah. So for those joining us, coping strategies were lacking, and it's true, his toolbox was not very big right now. So absolutely, he needs some more tools, some more coping strategies. One more, and then we'll move along. Mm-hmm. Right. So connecting to resources. What was missing in particular? What could we have done sooner for him, do you think, specifically? Yep. Mm-hmm. Yep. Yep. And starting that sooner would have been huge, as well as the START doctors that could have gone him on methadone right away or Suboxone. Okay, so a few other ideas, and this is from really our START proposal. So as a team, we are a grassroots movement, if you will, that is not funded yet, but we are hoping to one day have funding for the true addictions or START team. And with that, we built a plan of what we would like to see happen. So these are just some ideas and things that we would have liked to have done for Boris if we could have. So the first one is contracting. Contracting with patients is really important. It might be something that you've learned about in school so far. If not, definitely something to keep in mind. Contracting is having an agreement with a patient. So what are their responsibilities? What are my responsibilities? So what I like to do with these patients is sit down and say, what are your expectations of us, the hospital team? And then we have expectations of you. So sometimes we hear people say, you know, the doctors just cut me off of my hydromorph and now I'm in withdrawal, so I'm going to go use. So your expectation is that we give you hydromorph. Is that it, or is it pain control? Is it withdrawal? So really contracting around what they're hoping to get from us. And then we have outlines for them too. We're contracting with you that you need to be in your room for your treatment, for your doctor's visit. So really contracting is a big piece with patients. Doing an intake meeting with family, we know that there wasn't much support, but anyone who was available, as well as community people, he had a community social worker, sitting down together and making Boris's treatment plan and goals would have been helpful. And then a scheduled care plan. So letting Boris know, you know, you're on IV antibiotics 4 times a day at 700 hours, 1200, 1600, and 2100. You're expected to be in your room at those times. That is part of the contracting. And then that gives him a sense of control as well. He's lying in bed, he's in pain, he's bored out of his mind. So being able to say, I have control, I'm going to be in my room for treatment, provides some autonomy for the patient as well. Ongoing supportive counseling was lacking, as you guys have pointed out. And then a discharge meeting. So rather than just sending Boris, well, unfortunately Boris didn't get to that point, but what would have been nice is if he had gotten to that point to really set him up for success in the community. So Boris might have had a very different outcome if he had interdisciplinary care, and every single healthcare provider has a role in care for patients like Boris. Okay, now I will pass it. Do you want to just run through for...
So he saw lots of doctors, but maybe I would rather maybe hear from you and Meghanne about if you had been.
Okay, sure. And then we're going to give you guys a chance to put on your discipline hats too. All right, so social work. So I am a social worker. Queens does not have the program, so you may or may not have had tons of interaction with social workers. But basically, our scope is that we are experts in understanding the relationships between people and their environment. My scope actually uses the word diagnose, but I cannot diagnose mental illness or physical ailment. What I can diagnose, if you will, is what a person's environment, their social structure, their physical structure, how that impacts their day-to-day functioning and living. So expert in person and environment, if you will. Looking at a family system, we know for Boris, he had tons of trauma, probably not a great upbringing if both of his parents were drinking all the time. We know that he did not have a great physical environment. He lived rurally, which can be disadvantageous for some people. Social workers also look at financial security or lack thereof. We assess health and mental health status, vocation, so looking at did he work, was he highly educated, not so much, as well as linking people with community resources. So for a start, if we had a program up and running, what we would have done with Boris is individual therapy, family therapy, groups, so bringing together the multiple patients that are admitted at once that are like Boris to do some group therapy around comorbid diseases. Many of these patients have hepatitis, cirrhosis, and some other challenges. We do case management, so making sure that there's a good plan when it's time to discharge. We manage to work with the other disciplines and kind of facilitate everybody else in linking Boris. So again, resource connections and family education. The one big piece missing for Boris was that his family was not really available. His girlfriend kicked him out, so really providing that education. And I'll pass over to Meghanne for nursing.
Hi, guys. So there's a few nursing students here. So the big thing is that nurses spend the most time with the patients, right? I mean, I have the specific roles there at the bottom. They're doing the physical assessments, they're doing the med administration, they're doing the daily care planning, assistance with ADLs. A big thing about all these little things that we do for them, that's a perfect time to build a therapeutic relationship. And when we were talking earlier about when Boris didn't want to tell people that he was using, that's because nobody really built a therapeutic relationship with him. Maybe if like they talked to him for a little bit, maybe he would have been a little bit more apt to indulge, right? I just put here a key value of the ethical nursing practice is to promote the health and well-being of patients regardless of income, age, gender, ethnicity, and other socio-demographic characteristics. The reason I put that is just because I wanted to talk a little bit about harm reduction. So the values of harm reduction are consistent with the values that are outlined in the CNA of Code of Ethics. From my perspective as a nurse, if I was a nurse on the STAR team, I don't want to be doing a lot of harm reduction teaching. I'd like to be an advocate for that patient. So if he had some harm reduction teaching early on, he might have been able to inject more safely, meaning that he might not have gotten the infection that he did.
So we're actually going to talk about harm reduction at a little bit more depth, but maybe that's a good place to talk about it here. So does everybody, sorry.
Yeah. Sure. So in practice, in the hospital, we definitely work very, very closely, social work and OT. Within our scope, we both have that scope of psychotherapy. We look at assessments of how people manage in the community. And we do have a couple slides on that I consulted with an OT about, as well as a physiotherapist for their scope. But definitely there is some overlap. Does anyone have, maybe I'll go back one. Nope, that's the right one. Does anyone want to comment from the OTs? And again, we're going to give you guys an opportunity as well to do a little bit more brainstorming and work, but does anyone have any comments or questions about that? Oh, that's even better.
Okay. So a lot of people, when they hear occupation, they think of vocation only. So we broaden the scope of occupation, looking at everything from self-care to productivity to leisure. So can the person shower? Can the person socialize with the people that they want to? Can they go to work and do their gardening activities? All of that. And
There's someone over here to the right of you. Thank you.
Hello. So just to add on to Teresa's answer, we also look at mainly how people interact with their environments, and by interaction that means working, living, interacting with other people. So that would be also for his case could be interacting and entering into community resources and getting help doing some other things that can help him build his coping strategies.
Yeah, absolutely.
One last thing to add to that, occupation and meaningful occupation is the core of what we are about. So for Boris's case, a meaningful occupation to him was using, but he didn't receive the education on what the impact was of those occupations on his daily life. And he wasn't provided with the chance to explore other, more meaningful occupations that would have been promoting health and well-being.
Yep, absolutely, 100% that was missing. Yep. Yeah, we'll do one more and then we'll move along because I think that's a good lead into what we'll have you guys do for a bit. So one more comment?
So how soon, I'm a nursing student, how soon in Boris's care or in like general patient care should an OT be consulted to have like a holistic approach to their care?
Good question. I think one of your OT colleagues over here has the answer maybe.
So the hospital, it's in the first 48 hours.
Yeah. So I think what we'll do, if it's okay, I'll just move along if that's, is there a question?
Oh.
Absolutely. Thank you, everyone, for your comments. We appreciate them because especially we're not OTs or PTs. If it's okay with you guys, maybe we'll go past the harm reduction to get them time to do the group activity. Would that be okay? Yeah. Okay. So just in brief, we just threw up a couple slides about other care providers that could be involved just to help recognize that they're part of the interdisciplinary team. So dietitians are huge. A lot of patients who use substances may pay little attention to their nutrition, to their health, and they may use their income to get their fix opposed to buying healthy, nutritious food. So dietitians can provide a lot of education here. Education on nutrition, healthy eating on a budget, meal preparation is key to recovery. And in hospital, the dietitians are actually involved in making sure that these people have really healthy and nutritious meals. Okay. So then the next one is pharmacist, as you can see there. And like I said, we'll just skip ahead. Dentist has a role in oral hygiene. And the patient needs to be their own CEO and advocate. So that's another really important piece. Okay, so who's missing? This is where we want you guys to get together. So I think everyone's kind of clumped a little bit. So we're going to do that thing that everybody always hates, and I'm going to ask you guys to kind of stand up and move around a little bit so that there's at least 2 or 3 of you from different disciplines in a group together. And what we're going to have you do is we want you to put on your hats, as you've already started to do, to think about what you would do if you were Boris's occupational therapist, physiotherapist, physician, or nursing student. Hi. Yeah. Yes. You mean the whole discipline or the whole thing? Or?
If you don't regularly learn in this room, you can turn your chairs around to be in groups of 8 with the row behind you. That's how this room becomes a small group room.
Fantastic. Does everybody have... Perfect. Awesome. And the case study is coming around of the slides about Boris. So if you don't remember everything about Boris's health and social status, that's coming around as well for you. Does everyone have markers? Did they get passed out too? Okay, it looks like everyone's pretty much settled. So what we would like you guys to do is let's take maybe 15 minutes, and we want you to put on your discipline's hat. So if you're a nursing student, be the nurse, etc., and really what your role would be for Boris. And you can put this on from different hats. For example, if you're a medical student and you want to put on the cardiologist hat versus the psychiatrist hat versus the family doctor hat, do that. If you're a nursing student, you want to put on your mental health nurse hat, do that. So really look at different angles and pick what angle you liked best about how you would provide Boris's care. And we'll give you about 15 minutes for that. Does anyone need the case study? No? Everyone's good? Perfect. All right. Thanks, guys. We'll be back in 10, 15 minutes. And we'll walk around as well if you guys have any questions. We'll give you guys about 2 more minutes to finish up, and then we'll come back together. All right, guys, we're going to come back together, and I'm going to hand over to Meghanne.
Hey guys, you guys can just stay in your groups. We're probably just going to get somebody, if you guys can all just pick like one speaker from your group, and we'll just kind of get you to list off a couple of things that you guys have come up with, okay? Who wants to go first? What group wants to go first? Or do I have to pick? Anybody want to volunteer to go first? Anyone? Yeah. All right, let's start with you guys. You're right in front of me. What are some ideas you guys have come up with? And just read them off the page, like. Or I can just give you the mic.
Not like double microphone. We're good. Yeah, so I think we were still discussing kind of gaps that we noticed, identifying like the primary care connector, who was doing his meds, and is there a family doctor that could have been connected in the process. Looking at in hospital, we're wondering like a psych consult, recognizing that there were some signs for some psych supports needed, why that didn't happen, contacting the family and having a family support there, or even speaking with Boris and like having that conversation around like, are there family supports that you want to be involved in your care?
So can I ask, because you're right, so many gaps, it's absolutely ridiculous. Did you guys come up, though, with the information you have, what your scopes would be, or what, as care providers, your roles might be for Boris?
We were kind of getting to that.
Oh, okay.
Just wrote OT, and we're about to start doing our bullet points. So.
Oh, and you ran out of time?
Yeah.
Oh, I'm sorry. Does anyone just want to shout out what you would have done if you were the OT or the PT? Or? And then we'll move along.
Yeah. No? Okay.
Good points, though. There's so many gaps.
I was just going to say, as an OT, I'd probably go in there and actually try to start building that therapeutic relationship, talking to him about what his goals are in this process, what is important to him. Is he understanding all the information that's being given to him?
That's a great point, actually. That's a very good point.
what is his routine and structure within the hospital? So like, can we kind of put some structure in his day, include some other activities that keep him busy, that connect him to some supports within the hospital even. So.
Perfect. That's great. Great job, guys. The next group just behind. Sure, yeah. We'll just mention a couple of the gaps then. We can do that. That's fine.
We were just saying how you can kind of like the first step is probably a clerk taking like a good. Oh, medical student. I was sorry. Yeah. We were saying that the first step is likely like a clerk taking a good social history and building rapport, and maybe using it as an opportunity to provide some education. Yeah, and then hopefully referring to OT and SW as soon as possible.
Great, that's awesome. Okay.
Well, I'm just trying to make sense of them all, but harm reduction and addressing what is feasible and can support him where he is. Also important to always consider the support aspects, family support or strain, other potential supports, even if not to directly affect the psychological or physiological addiction, but to at least address depression, motivation, and all other things. And then exercise, lots of engagement happening here. So we have about 12 people on Zoom, and they're trying to discuss from their own roles and their perspectives what kind of support and what could have been done differently.
You guys way in the back. Any good points?
So a couple of things from the med perspective were like.
And sorry, what's your background?
Med.
Perfect.
Student.
Thank you.
Like probably some sort of like psych consult or like link to the addiction. So I think a big thing is like language and rapport, and obviously like you want to create a situation where it's safe enough that the patient feels comfortable to tell you if they have an addiction or if they're using, and we don't think that that was done well in this situation. So that
Absolutely.
was probably an issue. And with nursing as well, we talked about like having trauma-informed care. So when he went out to inject, there was probably some stigma associated there, and that led to it not being addressed correctly.
That's great. Thanks, guys. You got the big group way in the back. Yeah, super group.
Okay. Oh, yeah. This is a lot of movement. Okay. Can you hear me now? So we looked at it. So a few of us over here are RNs and also in the MP program. So we do have experience working in this nursing role. So nursing is really the first point of contact with the healthcare system. So there should have been more of a history there, and we build that therapeutic relationship. Therefore, like we're the first people to refer to other disciplines, and at KGH, nursing can actually refer to OT and PT without having a referral from the physician. And then we're also the communication with the family, and then translating the medical jargon for the patient themselves so they can be like a shepherd of their own care. And then we identify like the support barriers, which again, as NP students here, we like saw a huge primary care piece missing here, which were kind of why isn't he connected to stuff already from there. And then OT, again, social history assessment. Everybody's doing a social history assessment, med, OT, like, and somehow a lot of this got missed. And then OT can provide coping strategies and help him set goals and liaise within the community. and actually provide like housing support and help him discover meaningful activities. And then MD, we look at it again from primary perspective. That piece is missing, but then also like throughout like your assessment, you're getting that health history. You're looking for the red flags, monitoring the social history, and connecting to community resources. And
That's
then
awesome.
she started to write spiritual care as well, but we ran out of time. Yeah, go for it.
Just as we were sharing, I was thinking about the fact that
Go ahead.
For OT also, we could kind of determine and assess the roles that he really values and are meaningful to them. If he, as a father figure, really value his family and wants to go back to his family, then that could be a motivator for him to engage in harm reduction or other
Absolutely,
addiction-related
yeah. That's a good point.
interventions.
You guys, the PT group, I think.
I could speak on behalf of the physios, and I guess what we would start with too, there's not that much information about his like signs and symptoms that he currently presents with, so any like shortness of breath that he might be having, or even about his mobility. So one thing based on that, we would address that. So just maybe like a scheduled regime where you'd spend like an hour with a physiotherapist to work on some sort of mobility, like walking, based on his current symptoms, or any like we would also address any shortness of breath, so giving him some breathing techniques, also some energy conservation stuff, such as like pacing, prioritizing, positioning, just to also help that, like getting that blood flowing better. And that's kind of, it, I think. I don't know.
Thanks.
Yeah.
That's a big piece missing, because if we're looking at his cardiac status and no one's actually working to maintain it or improve it, like obviously he's going to go downhill even if it wasn't for the drug use. So, yeah, that's really, really great. How about other roles from that group? OT, nursing, medical student.
So I think it's a lot of what's already been touched on, but going through the order, in terms of the nursing perspective, again, the first point of care. So obviously past medical history, a full mental health assessment, also consulting the community, different nurses in the community, different clinics throughout the community to see who can help where, and maybe different perspectives, and then also getting transitioning in consulting social workers or occupational therapists. Going into that, OTs, our OT representatives were talking about different ways to incorporate activities throughout the day to work on that mobility. Also inquiring about the patient's family roles, general interests, hobbies, trying to find something to not force them to do some crazy change in their life, but something just to incorporate onto something they already enjoy. And then finally, educating about substance use and different coping mechanisms. From the medical perspective, it was brought up about there seemed to be like recurrent valve issues, and just inquiring about why there were those valve issues, and how that can be prevented from happening, and why it hasn't been focused on before. Also, though, he was at a peripheral care center, so how is his continuity of care? Is it just kind of, a huge issue happens and then he's able to get some medical treatment, or is he being regularly followed up and, his needs being met from that perspective? Also, in general, compliancy problems. But, yeah.
So he might benefit from some like community care planning as well with the community organizations. Yeah. The last two groups, I'm just going to get you to maybe say if there's something that has been mentioned already, just for the sake of time. Whoever wants to go first.
Hello? Okay. One of the points that we thought was a gap was that based on the information that we have, sorry my back is towards you.
Oh, it's fine.
I just know I talk low. So based on the information that we have, like especially for example, like going back to the medical history and like the medications that Boris was on, like so myself being an OT, but then also from a psych background, like looking at the different types of medications, realizing, okay, there looks like there's to be more of a history here, considering that he was on antidepressants. So what was it like that brought him to that state and feelings of being depressed and dealing more with those issues? So as an OT, we'd again go through like that social intake and history and like learn more about what issues he may have been dealing with before, and then also trying to address that as soon as we can. So that's why, like, even from placement history, it's always good to, when a patient comes in, to assess them all on the first day. So it's the busiest day for the patient because they are typically seen by OT, PT, and then consulting with the med and nurses. And so that's also because the team is trying to work like interdisciplinary together to try and make it all happen so that way the patient does get those resources and supports that they do need right away.
Great, thank you so much. That's awesome. You guys, last group?
I don't know if this has been said and I just maybe missed it, but another cool thing that OTs have just started doing is psychotherapy. So if a OT is licensed to be a psychotherapist, it's a really great role that they can also have, but even if they aren't licensed for psychotherapy, they can also do counseling and coaching and just kind of talking to the patient through. Another thing that we noted about nursing is that if he was spending a lot of time in bed, they also have a role in skin condition and ensuring that the integrity of his skin is being well maintained. And then also both med and nursing, we are looking at his medication history and maybe changes to dosage, potentially.
Okay, that's great. Thanks so much, guys. Okay.
To pass on, the Zoom people are saying, even though referrals and consultations to social work, OT, PT are useful, they're much less effective than a coordinated team who link face-to-face to ensure that all is going in the same direction and avoiding gaps and redundancies. So very important to consider team as the key. Which is why we're all here, right? Yeah.
A team.
A team.
Yeah, we'll get one comment, then I'll. You want to back up?
I just had a thought around safety planning. So actually, with the patient, engaging in a safety plan for if he is planning on using, like how he can do that safely if he is planning on leaving the hospital. Yeah.
Absolutely, safety is huge. I see a couple more comments. I think what we'll do, if it's okay with you guys, for the interest of time, because I'm just mindful here, we don't want to keep you guys past 6 o'clock, which is kind of the end of this. So we're going to pass out the slides, or I mean, they're going to get emailed to you so you can see the rest of them, because we do just have some more slides about the roles of each of the disciplines. Although we're not OT PTs, I did consult with one of my OT and one of my PT colleagues, so we have some information that is hopefully pretty accurate for the OT PTs in the room. The one thing we did want to talk about was harm reduction, and so what I think we'll do is I'll pass it over to Meghanne and Dr. Newman about that. Meghanne did bring in some kits from Street Health about different types of substances and what the harm reduction kits are. We'll leave that for just after 6 o'clock. Whoever wants to stay has time to stay and learn about the harm reduction kits. You're more than welcome to, but we respect that this is supposed to be done at 6, so if you have to head out, then that's okay. So what could have been done differently, really, in summary, let's get the methadone or Suboxone started faster, let's get the mental health looked at, and then let's do some harm reduction. Do you want to any final questions before we kind of wrap up, and then we'll do the harm reduction piece for anyone that wants to stick around? All right, awesome. You guys have been fantastic. Thank you so much. I know the biggest pain when I was in school was having to move seats to sit with a bunch of strangers, so thank you for that. We appreciate it.
So if anybody would like to see the harm reduction kits here as they are passed out at Street Health, come on down to the front and we will talk a little bit about that.